Welcome. My name is Maria Castellucci, and I'm a content strategist at Modern Healthcare, and I'll be introducing this webinar, Collaborating to Address Health Inequities in Underserved Communities. During this webinar, industry leaders from across the healthcare industry will explain how they are coming together in building proactive solutions to create a more equitable healthcare environment. A couple housekeeping notes before we get started. We want this webinar to be an interactive experience for our audience. You're encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. We have saved some time near the end of the webinar to answer your questions. Should you need any assistance during the webinar, please don't hesitate to contact us via the questions pane in your attendee panel. We'd also like to thank our sponsor, Quest Diagnostics. As the world's leading provider of diagnostic information, Quest employees work every day to uncover insights that empower better health. It's my pleasure to introduce our moderator for today's webinar, Alfred A. Edmond Jr. He's the Senior Vice President and Executive at Large at multimedia company Black Enterprise. Alfred, the floor is yours.
Thank you, Maria. And thank you all for being here. I welcome you on behalf of all of us here. To begin, let me introduce our esteemed panelists. First, we have Dr. Gary Puckrin, the founding president and CEO of the National Minority Quality Forum, a nonprofit healthcare research, education, and advocacy organization headquartered in Washington, D.C. We also have Nancy Brown, Chief Executive Officer of the American Heart Association, a 97-year-old organization whose mission is to be a relentless force for a world of longer, healthier lives. Carrie Hydash is the President and CEO at Family Healthcare Network, or FHCN, a federally qualified health center that serves hundreds of thousands of patients at 41 different locations in California's Central Valley. And finally, Steve Ruskowski, Chairman and CEO and President of Quest Diagnostics, the leading provider of health diagnostics in the United States, serving over 1/3 of the US population. Now, before we get started, I want to again emphasize a point that I think Maria touched on about how we're running the session and some of the technical objectives of the session. Those of you in our audience will be able to listen and view the seminar. You'll be in listen and view only mode. Your microphone and camera are disabled for bandwidth and sound quality, but we do encourage you to participate, and here's how. We'll begin with the discussion with our panelists, and we'll end with a question and answer session where audience members can ask specific questions. To participate, please enter your questions in the chat function. The goal of today's session is to provide you with insights on how our panelists are working together to increase health equity and to inspire each of you to take action toward this goal. Let me repeat, and I say this all the time, the success of a great conference, a great meeting, a great webinar is what we do after the great conference, meeting, and webinar. So let's make no mistakes. While we want you to be educated, we like to be entertaining if we can be. The goal is to get you to really take some action, whether in partnership with each other, or there may be some things that are unique to your constituency, your organization, and your mission that can help advance the cause toward increasing health equity. So we really hope that you will be engaged not only during this conversation, but really energized to do something after the conversation. So with that, let's get started. Let me open with why this is an important conversation for me personally. People that know me would probably know I'm actually a business journalist. I am probably the one non-healthcare leader in the room. But healthcare and health equity is extremely important to me. I'm a person who's personally committed to health and fitness and mental wellness as well. I have a standing appointment with my own therapist. I'm a competitive natural bodybuilder, and it's really, really important to me. But it's important to me for another reason when we're talking about equity. I look at health as an economic issue. We're talking about length of life. We're talking about quality of life. We're talking about how long you can extend your earning years, how much it's going to cost you to live longer if you live long, and what money you leave on the table if you die prematurely. So just as a quick example, if you're a Black man and your life expectancy is, let's say, 72 years, and you die 25 years prematurely, that is actually more than $1 million of earning power left on the table with an annual salary of only $40,000 a year, which is not that big a salary. So the implications of this conversation go far beyond just some of the things we think about with health, how we deal with illness, how we deal with wellness. There's a broader implications that feed into the disparities that our panelists are sure will address during the course of this conversation. So that's why I'm so thankful that I'm involved in this conversation, and I'm glad to be your moderator. So with that, let's get started. I want to start with a question to each of you as panelists. From where I stand, this conversation is critical, as I just said. Let's begin with a look back at this past year and a half. How do you see the current state of health disparities, and what has the pandemic revealed about the most important ways your organizations can help increase health equity? Let's start with Dr. Puckering. Gary, as a research and education organization, you focus heavily on data. What are some of the biggest disparities among underserved communities that you're seeing right now?
Thank you so much, Alfred. You know, when you think about it, certainly thinking about African American communities, it's just every place you turn, cancer, diabetes, cardiovascular disease. COVID put a real spotlight on all of these disparities. And we saw it in the hospitalization rates and the mortality that was occurring in the minority, specifically the African American community. And it raised the call to action. It said to all of us that the moment to intervene is now. And I have to say at the outset, we had a great partnership with Quest in this. One of the things that we did with the partnership of Quest and Centene, we launched a 5-year study to understand why minority populations were disproportionately impacted by COVID. We collected blood to do whole genome sequencing. Quest Diagnostic donated all of the lab tests. We enrolled 5,000 people into the study, and we're following them over 5 years, and it's really been quite a learning experience for us. So we just didn't observe and bring our hands. We got into the middle of it and tried to do something.
You know, I'm really curious as to how you use data to create better healthcare outcomes for underserved communities. And as a Black male who is now 11 years past surviving my prostate cancer experience, I know that early intervention, quick access to care is really, really important for long-term quality of life. And these are some of the things that we saw revealed during the COVID-19 pandemic for underserved communities. What role does data play in the ability to come out with better health outcomes for these communities?
You know, data is absolutely essential. We've been collecting health data now for about 20 years. We have a database of over 5 billion patient records. We collect data on 160 million lives per year, covering over 100,000 conditions. And my walkaway is there are no random events in healthcare. You can actually predict how many people are going to have a cardiovascular event at the zip code level, how many people are going to go on dialysis. And it gives us the power to intervene, that we can change the course of those numbers. And so when we look at health disparities, we see them as an opportunity to use data to drive change. It is the key to the problem.
You know, Nancy, the American Heart Association is not new to this game. You've been investing time, energy, attention, resources to reducing health inequities for just a very, very long time. Can you talk about the actions that AHA is taking today to prioritize addressing health inequities? A great example would be addressing disproportionate rates of hypertension in underserved communities and the role partnerships play in this work. And I got to say, I mean, we know that the COVID-19 pandemic exposed and exacerbated the disparities we're talking about today, but we still have huge problems with hypertension and other heart-related, cardiovascular-related events that actually are still, in many ways, more deadly in larger numbers than even COVID-19 in the long haul. So talk about your partnership with AHA and Quest and other partnerships that play in this work.
Thank you, Alfred, and thank you to Steve and all of our friends at Quest for bringing us together with wonderful friends like Gary and others. Let me just, on the topic of data, Alfred, you're absolutely right. You know, at the American Heart Association, we held our first scientific conference understanding health inequities in the 1990s, actually. And we have been committed to this work ever since. And here's why. If we look at death rates over the past 10 years, we can see that Black people are 32% more likely to die from heart disease than white people. And with stroke, Black people are 45% more likely to die from stroke than white people. And these, as Gary has already articulated, and Alfred, you have as well. The COVID-19 pandemic underscores the need for an equity-focused global health agenda that also focuses on addressing the social determinants of health and social injustices that keep people out of the system where healthcare can be made available. And let me just say, at the AHA, last year, right around this time last year, we released one of our highest scientific documents called a presidential advisory on the health effects of structural racism. And we then partnered that with 10 financial commitments of the AHA between now and our 100th anniversary in 2024, that these commitments are about $230 million of new funding for things like our quality programs in 2,400 US hospitals, like investing in research, our work in communities, and high blood pressure is a critical focus of this area. And we're so excited to work with Quest to make sure that we are doing a number of things. You know, as an example, we are investing to expand research and mentorship opportunities for Black and Hispanic scholars. We are looking at launching healthcare careers for over 100 diverse students at 30 HBCUs over the next 2 years. And at the same time, we're very focused on community programs to deal with uncontrolled hypertension. And I will just end my comments by saying that during the pandemic, rates of blood pressure control in this country that were already not good got significantly worse. This is why with our data, we focus on things through our Get With the Guidelines registry, on publishing papers, over 600 published manuscripts over the course of this program, and 11 from the past year alone, that looks at how Get With the Guidelines and our blood pressure programs can diminish biases in healthcare.
You know, Nancy, we talk about big issues, we talk about big numbers, we've heard the data is important, but this could be very, very personal. I mean, I'm literally just in the last 2 weeks, two of my friends' parents have had strokes. And so it's really key to recognize how this really boils down to what impacts our day-to-day lives, even if we're not personally affected. It's also interesting to note with what you shared, how important innovation is to this. That it's not necessarily a straight line from point A to point B, and you need a lot of partners, ideas, innovation to get things done. In this space, we're going to move the needle on improving quality of life and length of life, particularly as it relates to heart disease and related illnesses. Carrie, innovation appears to be a big core of HHCN's work in providing comprehensive healthcare resources in the communities you serve, and you serve a lot of people. Talk about the innovative approaches that you take in delivering healthcare, what you learned when it comes to creating better health outcomes, but particularly for underserved communities, and if you think FHCN can be a scalable model in creating a future of more equitable healthcare.
Great, thank you so much for having me today. Yes, I think at FHCN, we understand that creating better outcomes for underserved communities requires a community-based continuum of care to address the social determinants of health. As you said, we're talking about very global issues, but they're very personal. And you know, there are basic items that you can do, like recognizing for us that our patients don't typically work in jobs where they are allowed time off, so we have extended hours. We offer transportation to and from our health centers because many individuals don't have transportation. We have mobile medical and dental vans to go to remote areas. However, that's not enough. You know, again, seeing that what impacts the health of our patients is so much more than their clinical care. We've partnered with affordable housing agencies and co-located housing and health centers together so that we can connect them to housing, and people in low-income housing can be connected to us. We have large teams of enrollment counselors that spend time going over health insurance needs and connecting individuals to health insurance. We've created fit clubs in our communities because many of our communities aren't safe. People can't simply go out and exercise and get their daily steps in. We have to create environments for them to be able to exercise. Food distribution at health centers, going to individuals out in the fields and educating them on health because they don't have time to come into a webinar or to a local community center to talk about health. Or identifying that specialty care access is extremely difficult to get for our patients, so we added specialty care to our scope of services. having a community resource center where we can help children with homework, or a literacy program where we hand out books to patients and teach parents how to read to their children, financial literacy programs, all really connecting individuals to resources much greater than healthcare. So our focus is on serving the needs of our individuals. We have a large community health team that not only connects patients to our services, but connects our patients to other services and learns about what they need through community listening sessions, participating in coalitions, bringing all that data back to our clinical teams and our leadership teams, because if we're truly going to be effective in taking care of these patients that we are honored to care for, we have to have both a clinical navigation system and a social navigation system, and create a network of social service individuals across the whole community and address poverty at large, or else we will not eliminate health equities. And so your question about, is this a scalable model? Absolutely. FQHCs, this is the FQHC model, the Federally Qualified Health Center model, and it's been successful in communities across the nation. And I think it's the answer to dealing with health disparity. It's talking about poverty and other inequities and bringing all of us together to address all of those issues.
So I'm hearing so far data, innovation, meeting people where they are, because I think so often we think of healthcare is where you go to get it. And by then, if you're going to get it, probably things aren't going well. But we're talking about a model and approach to addressing disparities that talk about meeting people where they are and addressing those issues that don't quite seem like healthcare related, but they feed into what people end up doing that determines what kind of outcomes they're going to get. And I'm hearing a lot about collaboration, which obviously is a big part of why we're doing this webinar. That there's what we can do on our own as individuals and as organizations, but more importantly, to move the needle on this, we got to do a lot of stuff together. And I guess you have to work with a lot of people and a lot of partners and entities to get all those things that you're doing, from financial literacy to, transportation to housing, done. Even though people would say, well, you're a healthcare organization, why do you have to worry about that? Steve, that really provides a great lead into my question for you. Last year, Quest Diagnostics launched its Quest for Health Equity initiative, which is focused on addressing the health disparities in underserved communities that Carrie and Nancy and Gary have already kind of addressed in a really vivid fashion. Can you discuss the mission of this initiative and some of the barriers you've had to overcome to really make progress and move the needle on this whole issue of addressing health inequities, particularly in underserved communities?
Yeah, thanks, Al, for the question, and thanks everyone for joining us today. It's great we could have the time to have this conversation, and we're deeply engaged in it because of what we've all been through. As we all know, it's been a very, very trying 20 months since we've been working through the pandemic, and everything we talked about already, what we see for disparities in the underserved communities that we want to do a better job with, were really exacerbated by the pandemic. And there's two parts of that, Alfred. One is what happened with COVID and the consequences of COVID and how we managed that and fight that horrible virus that we're up against. But secondly is what we also have seen is, we're all not going to the doctor as often as we used to. And we're seeing that in the data that we have at Quest Diagnostics. So basic healthcare is not being taken care of, and we're paying the price for that today, and that's going to be a problem going forward. So when we saw this at Quest, we said, well, it's a good opportunity for us to step up and put our shoulder into this problem. And we said we wanted to do a few things. One is we wanted to earmark some funds. So we put some resources. We earmarked about $100 million to support this effort. But secondly, is money's one thing, but we needed to have some resources. So we put in place a dedicated program team with dedicated Quest employees to manage this program going forward, because we really wanted to have impact. And then we also realized that we can't do this ourselves, to your question. We needed to have partnerships, we needed to have specific programs. And so we reached out to different areas throughout the country and different communities of the country to put together programs that made sense for those specific areas. And in doing so, we wanted to make sure that we had quick impact within those areas. And as you said, Alfred, healthcare is local. So it does get down to specific towns and communities and specific neighborhoods. And so by way of example, we've set up COVID clinics in Puerto Rico to help with the response to COVID. Secondly is we work with the national Black clergy to raise the awareness and build trust in local communities around the need to get tested, get vaccinated, and take care of your healthcare needs in specific Black communities throughout the United States. And then also to the whole discussion around social determinants of health. It's not just medicine, it's basic healthcare. We've actually sponsored some work around nutrition with educators in a community in the United States. So today we have about 18 community projects. We're looking to do more, but it really is a team effort. We often say at Quest that healthcare is a team sport, and this is a good example of that.
You know, so I always count my touch points in a great conversation like this: data, innovation, collaboration, meeting people where they are, and this word trust. We found out during the pandemic that the issue of trust is huge. It was always huge, but it was magnified whether people trust what they're being told, whether they trust the institutions that are serving them or purporting to serve them. And in this case, for us to accomplish what we want to accomplish as part of the goals of this webinar, is us trusting one another across different disciplines, different communities, different cultures, to work together to come up with solutions. I want to ask each of you, starting with Dr. Puckrin, talk about the nature of trust and it being a critical element of effective solutions for addressing health inequities.
I mentioned that study that we were doing with Quest and Centene to look at the impact of COVID in minority communities. We were in 5 states working with FQHCs and collecting for each of the 5 FQHCs, we were enrolling 1,000 patients. And as we were working with them, the issue of trust is just unbelievably important. The FQHCs, because they were trusted voices in community, they were able to enroll community members into the trials very, very quickly. And then as we were working with them, we started back in June of 2020, so right in the heart of the virus, when it was really hitting communities very, very hard. And the partnership that we had with Quest when we were screening people for the virus, we were doing serology tests, and there were a lot of concerns in the community, a lot of disinformation that was coming into the community. And we were able to bridge all of that with the collaboration of the FQHC, Centene, Quest, and we really learned just a lot of really important things about how the virus was impacting communities. If you think about it, it was hitting multi-generational households with sometimes 5 and 6 in the family getting diagnosed with the virus at one time. People were concerned when they wanted to travel. So the heart of it, you can have great data, you can have great innovation, but if you don't have trust, you don't have anything, because it is that relationship with the community that makes it all possible.
That's a powerful observation, and I'm interested in hearing from Nancy, Kerry, and Steve, respectively. What's the biggest insight you learned about closing the gap of health inequity over what is going, literally an unforgettable past 20 months? And obviously, we're still working our way even through the current experience with COVID. But what's the biggest thing you've learned over the past almost 2 years of this particular battle in healthcare equity?
I can jump in. Alfred, thank you. And I just want to say on Gary's point on trust, I couldn't agree with him more. This is why webinars like this are so important, and partnerships like the one we have with each other and with Quest make such a difference. And I think we always need to remember that our job is to give voice to the voiceless. How do we make sure that our work is truly representing people and what they need. And what I think, about what's been learned in the last 20 months is that there is this awareness that the systemic issues that drive health disparities have been decades in the making. And so to dismantle the systems are, it's not going to happen overnight, but progress is really important. And I think, a way that we can speak about progress, whether it's how we can impact many people through policy change, like expanding Medicaid or child tax credits, those give large scale results. Investing in communities can have serious results, through our Bernard J. Tyson Social Impact Fund as an example. We've helped families avoid eviction. We've diverted pounds of disposable food to people in need of food security. These solutions can be adopted more broadly. And then I would just say we all have to be intentional. We have to be intentional about what we're doing, how we're working together, who are the people we serve, and what is it that people need from our organizations. And everyone has a role.
I want to remind our audience that we are going to be taking questions or answering questions soon. So please remember to put your question in the chat. And in a few minutes, we'll be opening up to questions from the audience. And we really want you to be engaged. We want to give the panelists a chance to address concerns that maybe we didn't think of when we planned this conversation, but we want to have a chance to address them. But before that, Carrie and then Steve, what were the biggest learnings you've had over the last 20 months as we address this latest chapter in our striving for equity in healthcare for all Americans?
Well, I think that over the last 20 months, we've definitely reaffirmed the need to be a trusted partner with those we're serving, and the importance of creating a strong network of organizations that are willing to address social and economic issues. I think we can't forget that we are the voice of those who often are unheard and unseen, and the impact of students having to work from or go to school at home without a system at home necessarily of support, insecurity in housing and food that it was exacerbated over the last 20 months is going to have a ripple effect that's going to exacerbate some of the issues we've been trying to address for years and generations, and we can't let there be a backslide for these individuals who already are sometimes on the brink of devastating outcomes, both socially and economically. And we have to come together and stand up even taller and stronger to make sure that we're pushing forward health equity and that we don't let the pandemic create a bigger divide. We also need to have a resilient workforce and invest in that workforce. The needs of our patients are dynamic, and that puts a lot of pressure on our workforce, and we have to be there to support them so we can take care of the communities that need us right now.
Carrie, you just make a really strong point. In my family, the family businesses are military service, nursing, so a lot of healthcare people, both kind of service oriented, but I saw it firsthand in my own family, the challenges that healthcare workers had. They were having, again, these are challenges that were exacerbated during COVID, but those challenges always existed. And so you're right, we have to address the caregivers as well as the people who are in care if we're really going to address these problems and really solve the gaps. Steve, what's the biggest thing you've learned over the last 20 months as we strive?
Alfred, I think what really struck me during the pandemic was the stepping up of everyone just to fight what we're up against. And what I found very motivating and heartwarming is it really was a connection of people in those relationships that got things going. And so Gary talked about Nancy and Carrie is, the people-to-people connection to really have some impact, had a significant impact on our fight and our participation in that, whether it was setting up drive-throughs with retailers, whether it was working with our commercial insurance partners on programs to address the issues that we're seeing, working with hospitals on trying to identify in the early days those COVID patients quickly and putting together new systems. It all got down to phone calls with people to people working on real problems. And so to me, that was incredibly amplified during this period of time, that really these connections, and that's the purpose of this conversation today, is to connect people to the problem.
Listen, we're going to now open for Q&A, and I'm going to say right up front, I was trying to prepare one of the questions to ask. I deleted it by mistake. So if you were the person that asked that question, I ask you to put that question back into the chat. And I apologize on behalf of all of us for that question being deleted. But let me start with this question. As Nancy said, this is not a gap. This equity gap in healthcare is not going to get solved overnight because it's generations in the making. But what can we do? And I want to start with Dr. Puckrin to accelerate our progress. Now that we did get a really strong wake-up call, because of our COVID-19 experience, what do you think we can do, and other panels can weigh into, to accelerate this? And I know a big part of it, I'm going to lead the question by saying a big part of it is the ideas that we can take advantage of, those who are listening to this webinar, to collaborate and move things forward, working together with ideas and action. But what can we do to speed up the recovery, if you will, from national healthcare inequities?
I would want to underscore two things. The first is the role of the business community. The business community can drive change. And the fact that companies like Quest Diagnostic, it's not just dollars. It's knowing the supply chain, knowing the touch points, bringing a whole set of knowledge into communities that may not be there. It's not just in the moment. You can drive permanent change. And so the engagement of the business community, I've been doing health equity for a long time. I remember Margaret Heckler in 1984 with the Heckler Report talking about health disparities. This is not new stuff, right? But this is the first time that the business community has stepped up to say that they want to do something. And then I want to speak specifically about the American Heart and Quest, right? So the African American community has the highest prevalence of hypertension in the world, right? There are no people on planet Earth that have more hypertension per person than African Americans. This program to address hypertension in the Black community is essential. We've talked about those stroke numbers. We've talked about those cardiovascular deaths. All of that is related to the hypertension that is rampant. I think the number is somewhere around 62 or 63% of all African American adults are hypertensive. And so this is a very, very big program that can drive a lot of change. And so here you have the business community partnering with the American Heart Association, reaching out to the HBCUs to drive change. And that's what I'm talking about. That kind of public-private collaboration can do a lot of very, very important things.
Gary, I think it's great points. Carrie, I have a question from you from our attendees, from Lisa Hollier, I believe the last name is pronounced. And it's a really important one because the issue of money, financial resources to fund programs is another big thing. And when you're talking about trying to close disparities. And the question is, how did your organization, how does your system finance the programs and the collaborations you've been able to implement? Whether it comes from government, public-private partnerships. Gary just mentioned the importance of business really being engaged and involved. But how are you addressing that issue, that healthcare costs, healthcare resources, and even the other programs on some level costs? What is your answer to that, and how are you addressing those things in your experience?
I think, like you said, it comes down to partnership. First of all, innovation takes money, and Quest in their latest ventures have really supported innovation and are allowing us to try different things. If we go back to hypertension, when patients can't come in to see us because there's a pandemic and when we can do remote monitoring, that takes support from industry to allow us to innovate in that way. It also takes partnership. We know as a healthcare provider, we can't do everything for everybody. And so bringing everyone to the table and knowing who has funding, who's expert, who has a skill set allows us to be more effective. Even in responding to the pandemic, we needed contact tracers to go out and to be in the community. Many of us didn't have the workforce to do that or the financial fortitude to do that, but we knew that the local workforce investment boards are funded by the Department of Labor and they could bring individuals in. It also meant taking individuals who were currently unemployed and giving them employment and giving them a pathway to future employment at the city or county level. So bringing all the different programs and partners together to capitalize on our expertise and our funding so that we can be more impactful as a community was key to the response.
Excellent, excellent, excellent. I have another really great question from Kenya James, and she's asking a question about the language of health equity in the profession. She says she's happy to see organizations like the American Medical Association and others publish a call to address the language and narrative of health equity. And I want to address this question to Nancy with the American Heart Association. What are you doing to change the language and the conversations and the mindset that goes into making health equity part of the regular permanent language of change in healthcare and the healthcare industry beyond the pandemic?
Yeah, you know, it's such a great point. And I just have to say, I smiled when I heard this question, because as we were launching our presidential advisory and our 10 commitments, one of the things I had our science writers do was to create a taxonomy of all of the terms and what was appropriate to use and not to use for our staff and for, you know, the 40 million volunteers and supporters of the American Heart Association. And I think the most important way that the narrative stays strong and that people understand goes back to something Gary said at the beginning. People have to believe there's a problem. And, you know, you help people understand there's a problem when you tell stories about real people with data that matters. I mean, this blood pressure number that Gary mentioned, you know, the 65% of African Americans who have hypertension, you know, most people in this country that have hypertension don't have it perfectly under control. That leads to strokes. This is what happens to families. It becomes very personal. And the way we can inspire followership to the agenda we all share is to make sure people see the impact to real people in their lives.
Wow. Steve, I got another great question. And let me say to the audience, if I mispronounce your name, charge it to my head, not my heart. But Christina Semiglia, I'm going to hope that I pronounced the name right. Steve, I think has a really great question. You talk about the 18 community service projects that you've already engaged in through the Quest for Health Equity initiative. Are these initiatives accessible by the general public, or to what degree are they? How accessible are these programs to the people who need it, who may not be part of a healthcare organization, but could be served by these projects?
Yeah. So Alfred, when we get into the specific projects, we have a clear scope of who we're trying to get to. We know exactly how we think we want to reach out to those people, and we defined objectives of how we're going to declare whether we're successful or not. So as we think about access, we think about carefully how we're going to get the access to the people we're trying to have an impact on, right? So I mentioned a nutrition program that was actually in Texas, in San Antonio, Texas, and we know exactly what we're going to do with the educators to reach specific students and communities to deal with that social determinants of health, which is important to all of us of having good nutrition in our lives. And so at the end, we're going to go back and we're going to reach out to those individuals that we wanted to have an impact to see if in fact we did. So everything we're doing and every one of the programs we've done so far, we'll continue to do. We're going to upfront understand who we're trying to get to, make sure we get to them, and then close the loop when we complete the program to make sure we done what we think we're going to get done.
Excellent, excellent. I think we have time for one more question, and the winner is Kelly Kesey. Again, forgive me if I don't pronounce your name correctly, but I think it's a really great question for Carrie. Carrie, tell us more about your program to educate in the field and provide some more information about your food distribution programs at your health centers.
Absolutely. So first, again, our patients, we predominantly serve migrant seasonal farm workers, and many of them don't have the capacity to come in during the day to see us, nor do they know they have a clinical issue to be addressed. So it's important for us to go to them. We call them quadrillas. We go out at their lunch hour, we take them healthy food. We do demonstrations about health issues that are affecting them or could potentially be affecting them. We actually do blood pressure checks and blood sugar checks, and we immediately can set someone up for an appointment if there is an issue, and we encourage them to be connected to services. Food distribution takes place in multiple ways. We have food banks and food pantries that come and do distribution at our sites. We have a community garden where we have families and communities come and take care of the crops at our health center, and they share their crops. And we've shown how individuals have come off of hypertension meds and others through having access to healthier food just through that program. And then in the summer, we know that so many children go without food because school free lunch programs shut down, that we transfer those from the school districts to our community centers during the summer. And our hope is, as we expand our literacy program, we're going to open a bookstore, and we're in an area where the closest bookstore, unless you count Target as a bookstore, is 45 minutes away plus, depending on what community you're in. So we're going to open a bookstore, and currently, if someone comes in for a well child check, we give them a book, a free book. But our goal is to have this big bookstore that should open next year, where children who come in to see us for our services can get tokens and go pick out their own book, or go in for reading programs, go in and get the food that they may not get during the summer, be connected to cooking classes about healthy cooking and eating, and try and give that holistic approach to total care versus waiting for them to have an ailment to come in and see us over later in life.
Well, all of you have presented such great examples and of ideas of what can be done. And in our preparation for this conversation, we talked about scalability. And obviously, we have an audience of people with varying size organizations, varying access to resources. But I want to stress this is all scalable and duplicable. It's not just about turning a small organization into a big organization. It may be partnering with other organizations to serve more constituents. It may be just taking an idea that's working in one community and saying we could do the same thing in our community. So I really hope that you have been inspired and energized to think about what we can do to really duplicate the wonderful example that these leaders are presenting to us with what they're doing with their organizations in partnership with each other and with others. That's all the time we have for right now. I know this is a big issue. We could talk even more, but it's more important that we are moved to action. And once again, I want to thank our panelists for sharing their insights. And I'd like to thank Quest Diagnostics for sponsoring and helping to organize today's webinar. I'm Alfred Edmond Jr. It was my pleasure to be moderator for this conversation. And let's all do what we can with this webinar closing out to move the needle on closing healthcare disparities.
Thank you again to our speakers for that insightful discussion. That takes us to the end of our webinar. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you. We'd like to once again thank the sponsor of today's webinar, Quest Diagnostics. To learn more, contact Steve at questdiagnostics.com. This webinar will be available on demand, and a link to a recording will be sent to webinar attendees within the next 48 hours. This concludes today's presentation. Have a great day.